Good afternoon and welcome to today's webinar, Advancing the Community Health Worker Workforce Through Law and Policy, brought to you by the Network for Public Health Law and the American Society of Law, Medicine, and Ethics. I'm Charles Strong, the Digital Marketing Coordinator at the Network's National Office, and I'll be your host for today's webinar. We strongly encourage attendee participation and would love to hear some of the thoughts and questions that you have, so feel free to submit them at any time during this webinar by using the Q&A tab on the right-hand side of your screen. All you need to do is click on that tab, select all panelists from the drop-down menu, and send your question. Your moderator for today's webinar is Colleen Healy Boufides. Colleen is a Deputy Director with the Network for Public Health Law's Mid-States Region Office, located at the University of Michigan School of Public Health. She assists public health attorneys, practitioners, and advocates to use law to protect the public health by providing technical assistance, training, and practical tools. Prior to joining the network, Colleen worked on state and federal legislative and administrative advocacy on behalf of Michigan's federally qualified health centers and as a commercial litigation associate for a large Michigan-based law firm. Colleen previously served as a member of the Michigan Community Health Worker Alliance Steering Committee. Colleen will be leading us through the rest of today's webinar, so Colleen, over to you.
Great, thank you, Charles, and good afternoon, everyone, and thank you so much for joining us today for this webinar on advancing the CHW workforce through law and policy. I'm going to dive right into introducing our excellent speakers for today's webinar, since you'll hear a very thorough introduction to CHWs and the role of law in advancing the CHW workforce from our first speakers. Our first speaker today is Dr. Colleen Barbero. She is a trained policy scientist and program evaluator. Colleen currently works with the CDC Division for Heart Disease and Stroke Prevention's translation team, where she specializes in economic, community development, and health systems policy analysis and research. Dr. Barbero is a current co-chair of the CHW work group at CDC and leads projects to develop CHW policy evidence and implementation and evaluation resources. Recently, she led the development of technical assistance for states considering CHW certification and other workforce development strategies based on findings from case studies completed by subject matter experts. Our next speaker is Siobhan Gilchrist. Siobhan is an attorney with a background working as an epidemiologist for the Georgia Division of Public Health and the DeKalb County Board of Health, as well as at CDC's former Epidemiology Program Office. Siobhan has been providing legal epidemiology and policy research and translation expertise to the Division for Heart Disease and Stroke Prevention's Applied Research and Translation team since 2010. Colleen and Siobhan will discuss legal approaches for advancing the CHW workforce and will provide an overview of the current landscape of evidence-informed policy components. Next, we'll hear from Darrell Fox, who is a community health worker with over 28 years of experience providing outreach, direct services, case management support and advocacy for HIV-positive adolescents and young adults, their families, and communities. He is currently a community health worker, health equity consultant at JSI, providing technical assistance and support for several Healthy Start, CHW, and HIV projects. He joined JSI in 2015 and for 2 years served as a technical advisor for the Massachusetts Department of Public Health Prevention and Wellness Trust Fund project, which employed over 70 CHWs across the state addressing diabetes, hypertension, asthma, and senior falls. Darrell is a proud member of the CHW workforce, continuing to serve in a volunteer CHW role, coordinating and staffing a young men's Rites of Passage program. Since 1991, Darrell has been involved in local, state, regional, and national CHW workforce development efforts, including serving as one of the founding members of the CHW section of the American Public Health Association and multiple other national, state, and regional associations and work groups. He currently serves as a member of the CHW National Core Consensus C3 project team and as a member of the founding board of directors for the National Association of CHWs. He has served as adjunct faculty for multiple CHW certificate and core training programs. Today, Darrell will discuss the importance of meaningfully engaging CHWs in policymaking processes and will discuss ways to promote CHW leadership in this context. Our final speaker today is Carl Rush. Carl serves as treasurer of the National Association of CHWs and has worked full-time with CHWs for 22 years. He has advised CHW policy initiatives in more than 20 states and groups of states for several national organizations. He has directed a community college CHW program and delivered workshops on CHW supervisor skills in multiple states. Carl was a lead author on the Health Resources and Services Administration's 2007 CHW National Workforce Study and co-lead on the CHW Core Consensus C3 project, which recommended a model scope of practice and core skills definition for CHWs used by many states and other stakeholders nationally. Carl recently completed work with the CDC on a national study on CHW credentialing and a related study of investment in workforce development for CHWs. He is a frequent speaker at national and state level conferences. And today, Carl will discuss lessons learned from states that have implemented laws relating to the CHW workforce. Please be sure to send your questions anytime throughout the webinar, and we will address those at the end. So with that, I'll turn it over to Dr. Colleen Barbero to get us started.
Great, thank you. Hi everyone, I'm Colleen Barbero, and today my colleague Siobhan Gilchrist and I will be speaking about the role of evidence in informing state community health worker law. So first I'd like to acknowledge some of our other contributors to this work. And this slide shows the CDC disclaimer. So our agenda for this presentation will involve discussing who is a community health worker. We'll also discuss early evidence in support of CHW policy interventions. I'll provide the landscape of evidence-informed state CHW laws, and we'll also provide resources for policy intervention implementation. So who is a community health worker? Sorry about that, I advanced a little too far. So this slide provides APHA's definition of a CHW. The CHW is a trusted member of and has a close understanding of the community served. This is among the most noted and distinctive attributes of CHWs as a profession, and it is valued by community organizations, employers, and community members. The trusting relationship with the community members enables the CHW to serve as a link between health and/or social services and the community. The CHW facilitates access to services and improves the quality and cultural competence of service delivery. Finally, the CHW builds individual and community capacity. The APHA definition has been widely cited and generally accepted by allies and workforce members alike as the CHW national definition. So it's important to know that there is considerable diversity among CHWs. This is because CHWs serve diverse populations. For example, they serve women, men, youth, elders, LGBTQ, as well as different geographic communities. For example, different neighborhoods, catchment areas, or zip codes. CHWs help to address social determinants of health and can help improve health equity for these communities. Additionally, CHWs may use different titles depending on the community served. For example, in Spanish-speaking communities, there are CHWs who identify as or may serve alongside promotoras, whereas in American Indian and Alaska Native communities, there are CHWs who identify as or may serve alongside community health representatives. Often the title used in inner-city communities is lay health workers, and patient navigators is often used in cancer prevention and control. There are many more different titles for a community health worker, which you'll see later in the presentation. Not only are the titles for community health workers quite different, but CHWs also differ in the roles they play and in their skills. Other ways that CHWs differ is in the issues they address, as well as in the settings in which they work and how they are paid. Now let's talk about CHW evidence in the policy process. Some of the most rigorous evidence in support of CHWs can be found in the community guide. Oftentimes, folks mistakenly think that the community guide reflects CDC findings. In fact, it's important to note that the community guide is a collection of evidence-based findings of the Community Preventive Services Task Force. These findings are based on systematic reviews of the literature, and they focus on population-based interventions that occur in communities and healthcare systems. The community guide recommends community health workers in cardiovascular disease prevention. In addition, they also recommend community health workers in the prevention of type 2 diabetes among people at increased risk for type 2 diabetes. There was sufficient evidence for this finding at improving glycemic control and weight-related outcomes. Also, for the management or control of type 2 diabetes among people who actually had type 2 diabetes, there was strong evidence of effectiveness found by the community guide in improving glycemic and lipid control and reducing healthcare use. These three interventions were also found to be cost-effective. Additionally, the task force recommends interventions that engage CHWs to increase breast, cervical, and colorectal cancer screening based on strong evidence of effectiveness. Studies included in the systematic reviews showed increases in cancer screening rates when CHWs delivered interventions alone or as part of an implementation team. The economic evidence for the cancer interventions is currently under review. All of the interventions on this slide are typically implemented in underserved communities to improve health and can help enhance health equity. The cost savings and return on investment are of interest to many stakeholders, especially payers. Cost savings can be used to sustain CHW positions over time, and ROI speaks to the value of engaging CHWs. The community guide found that the median change in healthcare costs per patient seen by the CHW per year decreased by $82 for cardiovascular disease prevention and decreased by $72 for type 2 diabetes management. Additionally, a CMS innovation study found cost savings of $138 per beneficiary per quarter for the CHW intervention. The ROI associated with CHW interventions has been estimated in many types of interventions and settings. Some published ROI estimates and studies are provided on this slide. As this slide shows, there are different ways you can use evidence, including the community guide recommendations and ROI estimates, to support advancement of the CHW workforce. Specifically, we are going to talk now about the last strategy of using evidence to implement policy interventions. As the figure on the right shows, CHW policy interventions can address occupational definitions and standards, workforce development, sustainable funding for CHW positions, and standards for research and evaluation. Together, policy interventions aim to increase CHW integration in health and social service delivery systems. Evidence-informed CHW policy interventions can be based on recommendations and practice-based evidence in the absence of research evidence. We also need to remember to monitor policy interventions after they are implemented for benefits and unintended consequences. This slide shows a general framework for generating and applying evidence in the policy process. Next, we are going to focus on my team's work to apply the first three steps of this continuum to community health worker policy interventions. These steps include early evidence assessment, policy surveillance, and implementation studies. We conducted the early evidence assessment using a method we developed for this purpose called QUIC. We collected a wide range of best available evidence and assigned and coded the evidence basis for 13 individual policy interventions addressed in existing state CHW laws. This slide provides the resources available and the methods used in this early evidence assessment. So this slide provides the results of our assessment. There were 10 policy interventions that had best or promising evidence bases. These included community health workers providing chronic disease services inclusion of CHWs in care teams, core competency certification for CHWs, CHWs certified when providing healthcare services, standard core competency curriculum, Medicaid payment for CHW services, specialty area certification for CHWs, inclusion of CHWs in decision-making, specialty area curriculum for CHWs, and defining a CHW scope of practice. And then there were also 3 policy interventions that were supported by emerging evidence bases, and these included private insurer coverage, educational campaigns about CHWs, and grants and incentives for workforce development. There are a few important caveats to note here. Basically, quick results say that the evidence base rises to a certain level for each type of policy intervention. This doesn't mean these interventions work independent of other legal provisions or other policy interventions in the assessment. It just means the evidence base is stronger. Also, the evidence doesn't include direct studies of the impact of law, which is why it is an early evidence assessment. We publish our early evidence assessment results so that they can be used as decision aids or support. This is intended to provide information for policymakers to use when considering their approach to enacting a law. We are not proposing model policies, nor are we endorsing or recommending any one approach. As we'll discuss later, these results can be used by stakeholder groups led by CHWs to determine the appropriate approach for a state. So now I'll turn it over to Siobhan to discuss our policy surveillance of state CHW laws.
Thank you, Colleen. Our team at CDC applies legal epidemiology principles and methods to our policy work with the goal of understanding which types of laws are likely to improve public health outcomes. Colleen emphasized the strength of the evidence from the Community Guide report in support of using community health workers in chronic disease prevention. For this and other reasons, our team has been focusing on laws addressing the community health worker workforce across the country. In addition, legislation, particularly at the state level, has served to establish the basis for community health worker stakeholders to have a formal role in the CHW workforce development process. Notice and comment rulemaking provides a further opportunity for community health workers to educate state agencies about their roles and skills and the value they bring to diverse, often hard-to-reach communities within the state. Some states are also amending their Medicaid state plans to incorporate community health worker services for Medicaid populations, thereby establishing a sustainable funding mechanism. Our policy surveillance typically focuses on state law. We collect and analyze law using Westlaw Next and state legislative and regulatory websites. We start by collecting and reviewing enacted statutes and agency rules or regulations. We also review session laws, particularly for historical analyses. Depending on the topic, we may look to state constitutions, executive orders, and agency administrative law judge opinions, and case law to assist in scoping the legal issues or for the analysis. However, we do not look at pending regulations or bills, contracts, or laws or regulations that were not at the state level. To identify laws specifically relevant to the community health worker workforce, our legal analysts used the 21 search terms on this slide. We found that many states had laws that addressed only one of these types of community health workers. Of note, patient navigator laws were excluded if they were tied to health insurance reform. Colleen mentioned the evidence analyses that our team conducts. We identified 18 policy interventions relevant to the community health worker workforce, of which 10 were aligned with an evidence base and we considered to be evidence-informed. And the other 8 had either emerging evidence or are relevant to the implementation of the law. We have been tracking the changes over time. Here you can see the number of states with a law authorizing or requiring each policy intervention in light blue in 2016, compared to the dark blue bars of data for 2019. The most significant change between 2016 and 2019 was an increase in the number of states from 13 to 18 that define a community health worker in law and that specify community health worker roles and responsibilities. We've also seen increases in the number of states, as in 3 states, adopting laws that include community health workers in Medicaid managed or team-based care and community health worker core competency certification. In 2016, 4 states, Texas, Massachusetts, Oregon, and New Mexico, had laws requiring that community health workers be included in developing the community health worker certification process or the CHW curriculum, an important component of developing the workforce. For example, Massachusetts required the Department of Health to convene a statewide advisory council to include, among others, the Massachusetts Community Health Workers Network, to assist in the study of community health workers and to develop recommendations for a sustainable CHW program. In 2019, there were no new states with law that requires community health worker involvement in decision-making. To better visualize how state laws are spread geographically, here we see a map that shows which states have the best and or promising evidence-informed policy interventions as of January 1st, 2019. Oregon had 8 of the 10 best or promising policy interventions, as you see in dark purple. To date, no state has addressed all 10 interventions in law. Also, in 2019, Arizona adopted a law including a community health worker definition, authorizing CHW core certification, and a standardized core curriculum. We also found some changes over time, although the data for 2016 are not shown here, in the eastern states, with Ohio, Maine, and Massachusetts enacting more of the evidence-informed policy interventions since 2016. Connecticut and Maryland recently adopted a community health worker law for the first time to guide the development of a certification process or accreditation process for training. Here we see states with law authorizing community health worker certification recognition in blue, state shaded in blue, a core certification process, the yellow circles, Medicaid private reimbursement, which are the purple circles, and or community health workers in managed or team-based care, which are the black circles, as of 2019. Across the country, we find 12 states and DC with law including community health workers in team-based care and or Medicaid reimbursement. 11 states have laws recognizing community health worker certification for compensation for their services or other benefits, the state shaded in blue, and 9 of these 11 states also authorize a core community health worker certification process, as seen in the green circles. As of 2019, Maryland, Rhode Island, and Ohio incorporate community health workers in team-based care, and Maryland, Arizona, and Nevada now have adopted or amended their community health worker certification process. Other new developments in 2019 include a mandate in Ohio for certain managed care organizations to provide eligible recipients with services provided by a certified community health worker or public health nurse. Additionally, Oregon may grant reciprocity or credit for national or non-Oregon certified traditional health workers, including community health workers. We also found that New Mexico enacted a law that requires a Medicaid managed care organization to employ or contract with a Native American care coordinator or community health representative if a Native American member requests assignment to a Native American care coordinator. Of note, community health representatives typically work with Native American populations and fall under the CHW umbrella. However, outside of Indian Health Service policy, they are often not included in state-level policies. Moving on, this map shows some of the funding mechanisms for community health worker engagement and workforce development as of 2019. States shaded in blue, 5 states and the District of Columbia, have law authorizing workforce development grants or funding provided by a state government agency. For example, Maryland recently authorized a state community health worker fund and funding appropriated to the Department of Health to establish certification and training. Some states are approaching sustainable funding mechanisms through other means. While the green circles show 6 states that have Medicaid or private reimbursement for community health worker services addressed in law, The purple squares indicate 17 states have or may be in the process of obtaining Medicaid state plan amendments and or waivers. These data were pulled from the National Academy for State Health Policy and ASTA websites and consultation with subject matter experts. However, some of these states might not have achieved a waiver or a state plan amendment yet. Okay, now I'll talk about some of our implementation resources. Our team has conducted several studies examining the approaches states have taken to advancing the community health worker workforce. And we have learned that there are multiple strategies for promoting the inclusion of community health workers when considering and implementing policy interventions which may but don't necessarily involve legislative or regulatory approaches. Such strategies may involve including community health workers in a state and public department planning, priorities, and programs, holding annual community health worker summits, and conducting statewide surveys of the workforce, ensuring community health workers have a majority voice in decision-making that affects them, and supporting the development of state and regional community health worker associations and networks. While many of these activities and processes could be and have been addressed through state law, more frequently they are addressed informally. Yet they play an important role when workforce development policies are being considered and implemented. For example, Rhode Island has integrated community health workers into its healthcare redesign and workforce development plan. Certified CHWs are engaged as community liaisons within Rhode Island health equity zones to link patients to evidence-based chronic disease programs. In Arizona, stakeholders hold an annual community health worker and promoter conference to convene community health workers from across the state. Arizona also conducted a statewide survey to make decisions about workforce development. As a result, the Arizona Community Health Worker Association participated in developing Arizona's legislation to establish a statewide community health worker certification process. Darrell and Carl will be providing more detailed descriptions of implementation strategies in their presentations. In closing, you can find the CDC developed resources referenced today on our website. These include the Community Health Worker Toolkit, our Policy Evidence Assessment Report, several state law fact sheets, and some forthcoming technical assistance documents. And now I'm going to turn it over to Darrell to provide the remainder of the presentation.
Okay, hello everybody. I hope you're doing well. So this is Darrell Fox, and I just want to thank everybody, and I'm honored to be presenting here today as one of the representatives of the CHW workforce. I chose the title of this segment to reflect almost 3 decades of engagement observations in the CHW movement, particularly related to CHW policy development. I will talk a little bit more about some of my experiences related to the development of local, state, and state CHW legislation and policies, and some of the challenges faced by the CHW workforce and our capacity to lead some of these efforts, or at the very least, to play a critical role and meaningful roles in engaging and guiding development of laws and policies that ultimately will regulate or guide our workforce. I use the word equitable purposely in the title because of the health equity lens I and other CHWs through the world. I observed that when it comes to the development of policies and legislation related to community health workers, there is an imbalance or an equity in the role that CHWs have played in some states. There's a variety of reasons for this dynamic, some of it related to the ability and the availability of CHWs to allocate time to participate in meetings, activities, events, planning, strategy sessions, and even really just to keep up with the knowledge base related to CHW policy development, with all the reports, communications that pretty much happen daily on this topic. And so I know this call is, we hope to be one of many calls that will help address some of these inequities, and we'll only be doing a short dive into some of that now, but I'm hoping others on this call will continue to assist us in moving forward with these efforts. So a lot of you all, whether you've been at recent conferences, trainings, or areas where you've heard the mantra, nothing about us without us. And it's been one of the overarching themes and rallying cries in the CHW movement to give voice to the principle of CHW self-determination, or some of you all who know about the Nguza Saba, we call that Kuji Chakalia. Our workforce really needs to be in the driver's seat, leading efforts to define our workforce, our scope of practice, training, and credentialing. I can tell you that I've been blessed over the last 25 years. I've been on the ground in over 20 states in 2 countries and been able to be part of conversations and meetings about CHW policy and advocacy development. I've been, in fact, involved in developing some of those materials as well, but unfortunately, I've seen too many examples where, although some of the allies and partners have expressed support for the nothing about us without us mantra, in practice, it was not being observed, and CHWs were not in prominent roles or equitable roles in the process. I will tell you, I'm glad to say that once, in many cases that has been pointed out, task forces, organizations who are kind of leading efforts around CHW workforce development who have seen this dynamic have righted the ship and for the most part have been able to develop ways and strategies to include CHWs, some of which you heard earlier from Siobhan and Colleen. Again, there are various reasons why this paradigm exists related to CHW's role or lack thereof in some states. And to address some of these reasons and to shift this paradigm, I'm asking everyone on this webinar to examine the role that you currently play in ensuring CHW leadership and equitable engagement in any of the policy and workforce development efforts that you're engaged in your state or that you know of. It's critical that we all have a role to play and that we find that role and play that role in embracing CHW self-determination. For CHWs on this webinar, it means working with your supervisors, your administrators, to heighten awareness and build support for your day-to-day work, as well as for your involvement in professional and workforce development opportunities, including supporting your involvement in efforts to develop policies that will ultimately help to strengthen and support the role of community health workers and also builds our capacity to be more effective and efficient, which benefits the communities and also the agencies that employ CHWs. For the employers, funders, policymakers, policy advocates, and allies that are on this call, it means truly embracing CHW self-determination as a guiding principle to ensure CHWs have an equitable seat at the table in any CHW policy room where we're being discussed, where you actually have a seat at the table. As we shouldn't just be on the menu, as some of you have heard this before, or asked to make a guest appearance, but not playing. We shouldn't just be on the menu, and that's, sorry, I just got confused. That's the kind of thing where we say, you know, if you're not at the table, you're on the table as part of the menu. We also ask folks to fight against potential tokenism and other things, that you have multiple CHWs engaged in your processes, and maybe not ask us to have a guest appearance or cameo, but to play a recurring decision-making role. I tried to make funny with that paragraph, but I might have messed it up, but I hope you all get the message that I'm trying to articulate. For everyone on this call, it means helping to ensure that there are more opportunities for CHWs to be able to build their knowledge base and tools to be able to step into leadership roles and policy development on the agency level, local, city, county level, as well as on the statewide and national level. Having forums like today's webinar, as well as meetings and conferences where CHW leadership and policy development skills building sessions are offered, are a great way to address this paradigm and this issue. CHW networks, associations, alliances, coalitions, and training centers have and can continue to play a critical role in helping to build the legislative and policy development skills and capacity within the workforce. And the employees and funders can also help ensure CHWs are able to regularly participate in these opportunities by developing policies that support their ongoing continual training and professional development opportunities. Again, I want to thank Colleen and Siobhan for sharing some of the strategies for CHW engagement earlier. I've seen some of those strategies in action on the ground, including several state health departments and Medicaid offices that were engaging CHWs on task force in groups while discussing integration of CHW language into state Medicaid waivers and the state plan amendments, and also while developing CHW state definitions, training and credentialing programs, as well as regulations. Some of us who've been involved in drafting legislation in some states, including my old home state of Massachusetts, actually baked in a percentage of CHW participation into some of those task force workforces, and including developing language around the membership on our state's community health worker board of certification that included a 50% CHW membership on our board of certification. I've also seen some great investment from public and private funders supporting development and sustainability of local, state, and regional CHW associations, networks, coalitions, alliances. Some of this support has gone to supporting advocacy and policy development, capacity building, training, materials, education opportunities, and I would love to see more of that as a result of this conversation, but also I know that some of you who are on this call are engaged in trying to ensure that there are opportunities to continue to support CHWs in the roles of advocacy and policy development by giving us the knowledge and tools we need. Okay. So many of you all have read the C3 report, which came out earlier this year, but for years, advocacy has been one of the core roles for CHWs. And that role has been expanded from first kind of focused on advocating for access to quality and culturally competent care and services for our clients and communities, shifting a little bit more, while that still continued, shifting to advocating for our workforce to have increased access to workforce development opportunities, living wages, career opportunities. And while that simultaneously goes on with serving our communities, we've also now shifted, maybe in the last decade more and more, to advocating for local and national health and public health policies that support our communities, our agencies, and our workforce. Many of us have done this on our own time, but I've been happy to see support from allies, partners, employers, and funders in supporting CHWs in these roles. While policy development has not been codified as a core role for community health workers, there are many examples where CHW networks, associations, and/or training programs have integrated CHW policy development, knowledge and skills building training into core and continual training opportunities. I even know one program that regularly plays a clip from the old Schoolhouse Rock about national legislation development. I know you all know it all, and you all should be humming it. Yes, I'm a bill, I am only a bill, and I'm sitting here on Capitol Hill. If you recall, that short clip goes really into the entire process on Capitol Hill, from a bill to second reading to hearings to potential successful or back to the drawing board. And just those basic images and that basic information and knowledge, building that into training and learning opportunities for CHWs can help go a long way towards looking at the national piece, but it also helps us find information and knowledge related to our local processes as well. One example I wanted to share with you is based upon my experience as one of the founders of our CHW Association in my old state of Massachusetts. Many of the early leaders in the movement in Massachusetts had some experience with policy development. I personally grew up in a house where I learned about local and state policy and legislation development at an early age, as my mom was a legislator in the House of Reps in Massachusetts for 30 years. And I found several kindred spirits of CHWs who, in a way, were frustrated doing the day-to-day work and helping clients, only to bump heads against systems that if we just could change some of those systems, we could help hundreds of families in one fell swoop versus trying to do it day by day, door by door, home by home. So while developing our statewide association, we were pulled into some, and this is in the early 2000s, some of the statewide policy coalitions at two of our state's leading advocacy groups, including Healthcare for All, under Community Catalyst, and our State Public Health Association. Some of the CHWs that got engaged in these coalitions expressed a need to better understand not just about local and state policy and legislative processes, but also just about the language used regularly in the development process. We're sitting in rooms with consultants who do policy and legislation, advocacy, lobbying, et cetera, and you get lost in the language. And so we decided, with support from the Blue Shield Foundation of Massachusetts, to spend probably a good solid 3 years developing and implementing a CHW advocacy training program, including a CHW advocacy toolkit, where we spent hours defining terms, demystifying terms and processes, describing in great detail some of the local, state, and federal level policy and legislation development processes, as well as providing some skills building and practice opportunities for CHWs to apply this new knowledge by developing materials to support CHW's role in policy development and initiatives that were already occurring in the state, and setting up meetings with policymakers and legislators, and helping to draft legislation related to community health workers in the state, as well as in helping to draft policies at agencies, including things like orientation guides and some of the rules at the agency level that govern CHW's practice. We also had some of our legislative allies present during these trainings to groups of CHWs to kind of demystify legislators, to have people understand that the folks that we are trying to engage in developing policies and legislations are, and many times from the same communities we are from, and has some of the same experiences, and trying to use those experiences to make that connection between the workforce and those who are the policymakers and legislators in our states. The advocacy training project also led to an annual community health worker advocacy days. Those occurred annually in my old home state through 2013, and it really helped us move the CHW policy legislation step by step, with CHW leadership guiding the pathway step by step. There was a core group of us who were kind of in the boiler room developing some of the early legislation in our state. And it was a group of 4. And there was an American Public Health Association policy asking folks to, when you're bringing people together to talk about CHW legislation or policy, to have a 50% CHW participation. And it just so happened that our core group had 2 CHWs, a rep from our state health department and our state public health association as the core group that then collaborated closely with members of the CHW Association leadership, the CHW workforce, our legislative allies, and other key stakeholders to develop a strategy and a plan in which over a decade we were to build upon policies to first look at our workforce, define our workforce, to look at, survey our workforce, and then to use that ultimately recently to develop legislation around CHW credentialing, once again led by CHWs. The legislation was successful in one session, and after many years of trying, and I think Carl will talk later about some of the frustrations of even when we're successful, it may take multiple legislative sessions, it may take multiple years to develop regulations that are responsive to the workforce, but ultimately it's worth it. And we went live with credentialing in Massachusetts last year, and there's great hope that some of the consequences that the great intended consequences we wanted to happen would happen, and some of the unintended consequences that might not be good for the workforce won't happen. And that's for another talk. I also want to note that because of this true connection between members of the CHW leadership in the state and some of our policymakers, as well as our leadership of our health department and our public health association, it was really a true partnership, and I think that helped guide it, and I hope there are other states that can talk about this connection between members of the workforce and leadership in the state, and how it can be genuine, it can last for decades. We've developed presentations as well as done different publications related to this work to try to help the field kind of see and understand the importance of those relationships, particularly in supporting the CHW policy and legislation. Okay, I'm getting close. So I wanted to just kind of wrap up and close with echoing a few of the messages I've tried to articulating over this, and that is that in order for CHWs to truly have an equitable seat at the policymaking table, we need access to the knowledge and skills to ensure that we can truly make an impact and difference while at the table. We need everyone who's at that table or who is setting up that table to embrace the need for CHW leadership and also to find ways to support us in developing that capacity as a workforce. For CHWs, we truly need agencies to embrace advocacy and policy as a vital skill and as a potential core role or lead role for the CHW within that agency and community. I've seen movement toward this in several fronts, so I have a lot of hope that that will continue to happen and that the employers and funders of CHWs will in fact assist us in getting a more equitable seat at the table of CHW policy. It seems that every day the train leaves the station on CHW policy development, and CHWs truly need to be able to jump on that train, even if it's already moving, if they're not already on it. And you probably need to know how to buy a ticket, but once you are there, you need to be ready to ensure that the train is on the right tracks and that you can help be part of drafting what is the end result of the work that folks are doing while on that train. Another area of growing interest around community health workers is helping the workforce understand the evidence that informs the policy. Many CHWs have been engaged in studies, surveys, and in some cases in initiatives that provide reports around CHW evidence, as is the case that Colleen and Siobhan just described in their work. And I think that this is a growing area of development that I'm hoping others on this call can help CHWs be part of. It means creating forums and opportunities for CHWs to actually consume some of the evidence, to actually shape some of the reports on this evidence as they are produced as well. Again, I ask all of you to look at your own role that you play and make an assessment on how that role is supporting CHW leadership and policy development, and take your own personal responsibility for shifting the paradigms that I've discussed. So next, I will turn the ball over to Carl Rush. And Carl, you have the ball.
Okay, so let's see. I am not getting control of the presentation yet. Is there something we need to do?
You may have to say yes, Carl.
There we go. There we go. Okay. Okay. So thank you, Darrell, and thank the network very much for hosting this. It's a very timely topic. There is a lot going on right now, and I want to add a little bit to the perspective, the two sort of key perspectives that we've heard from. One being the technical experts in policy development and the all-important work that they're doing in capturing what's going on from a legal and technical standpoint, and the practitioner viewpoint, because I can't reinforce enough the points that Darrell has just been making about the crucial significance of engaging community health workers being engaged in policy development and implementation. Before I launch into this, just a couple of quick observations. First, that we've heard a couple of points about a national approach to policy also being important. We're focusing mainly on state level, but there's a good example, as Siobhan mentioned, the Community Health Representative Program, which is funded through the Indian Health Service, and the entire funding of that program is threatened this year in the appropriations process, as it has been on occasion in the past, and an important strong response is needed for that. But we are going to be talking about state policy here, and I think it's crucial to recognize that you're the best judge of, or colleagues and allies in your state are the best judge of what works in your state, and politics is the art of the possible, and clearly the states differ in terms of how things get done. It boils down to that. So it's always important to be involved with people who really know and understand how things get done. My comments are going to be somewhat subjective here, and reasonable people may differ with my assessment of or my classification of what's going on in particular states. That's okay. I mean, that's of the nature of politics and policy development, and I certainly don't intend to offer these assessments, these subjective assessments, as anything pejorative or negative about a specific state. That's not the case at all. Again, because what works in one state doesn't necessarily work in another. So I want to proceed with a number of things that I would like to cover very briefly in all of this. The policy process in states has varied. In some states, it has been very slow and steady, and as Jarrell mentioned, in Massachusetts, for some folks, it was agonizing, but it was necessary because that's the way things got done. And then there's some states that, because of the impatience of state government itself or other stakeholders, they've kind of jumped ahead very quickly, and in some cases may have missed some important steps in terms of stakeholder engagement. The process varies by state in terms of whether the state government, in particular the state health department or the state Medicaid office, is driving the bus, so to speak, or whether other stakeholders are doing that. I've observed some differences among state governments in terms of whether they are really seeking out a role in this process or are trying to avoid, for different reasons, playing too prominent a role in it. The role of Medicaid or the state Medicaid office varies a lot from state to state, and is crucial because of the linkage between the Medicaid payment policies and other areas of policy in the state. I mentioned a minute ago about the connection between state and federal policy. Things are not always terrific in terms of the congruence or the logic of the relationship between state and federal policies, but we do have to contend with that. And then I'm going to finish by talking about what some of the stumbling blocks or barriers or impediments have been in some states to this process. There have been some states that have taken a long time, and in some cases been frustrated by the duration of this. There are states like Arizona that have been at this for quite a number of years. It is in the long run, in most cases, the deliberate process pays off, but it can be very frustrating. In some states, things happen rather quickly. In Ohio and Texas, which were the first two states to implement certification of CHWs, it is arguably the case that they sidestepped a lot of involvement or comment on the process in order to hurry something into implementation. In a similar case, the state kind of, in Rhode Island and Indiana both, the state kind of preempted a process that was already underway in order to get something going fairly quickly. It is debatable whether they had enough involvement of stakeholders in it. There have been a number of states where the state legislature has mandated a work group or a task force or a study committee or whatever that have done their work honorably and then find that the process stalls for a period of time. And that is not unusual. In that one of the ways the legislatures sometimes take a pass or kick the can down the road is to say, well, we'll form a study committee. And that can be, if you're not careful, can be kind of a dead end, or at least run into a number of speed bumps down the road. Illinois and Maryland had legislation creating these committees in 2014. They completed their work and then things stalled substantially. There are a number of states that have been working at policy kind of in a piecemeal way, but they've made progress regardless. And there are many reasons why they kind of had to do it that way. So that California, for example, had a Commission on the Future Health Workforce had some strong recommendations on CHWs, but their recommendations were not very aggressive at the end because it is going to take further work to bring stakeholders along with whatever is going to work for California. The process is sometimes largely driven by, and in some cases it has been by the state innovation model funding that some states have gotten, but the Massachusetts Department of Public Health was clearly in the driver's seat, even though they did a remarkable job of engaging, particularly the state CHW Association. And in Texas, for example, my home state, the committee that started out advising on certification has become a leadership body in terms of promoting other things related to CHWs, even though it's not part of their statutory mandate. In some other states, the state has been supportive, but has been reluctant to step out front in terms of leadership on the field. And Michigan is a particularly interesting example because they are not listed as officially having certification, but the Michigan CHW Alliance has taken leadership in developing standardized or best practices training for CHWs, which has become widely accepted and is now for many employers the de facto standard, such that completing their training is tantamount to, equivalent to a form of certification, even though it is not officially recognized as such by the state government. There are a bunch of states that are experimenting, though, with pieces of the policy environment. Oregon has been particularly aggressive through their coordinated care organization structure that they have developed. But other states are experimenting mightily through things like the Health Homes program, which is like a medical home for people with complex needs. Minnesota was out front in terms of proposing reimbursement for CHW services going back to 2007, 2008. I think it was finally implemented. So there is plenty of room for that. The states indeed can be the laboratories of democracy, and we see this in this field. In terms of what role the state government sees itself in or what they would like to do, that is affected by a lot of things. Anti-regulation climate, anything that looks like regulation, even though certification as it exists right now is voluntary, it does not regulate who may do the work. It is a voluntary system for documenting, a form of documenting someone's qualification to do the work. The cost of administering certification gives many states pause. They would like to find a way to avoid that. They usually end up supporting certification through application fees, which has some problems in terms of equity, as I'm sure Darrell and other colleagues would agree. Who controls the training? Is it controlled by the field, by the state government, by other stakeholders? Arizona is very interesting in that the state CHW Association is the party that sets standards for CHW training programs, and they will be the ones issuing accreditation or certification for training programs in Arizona. I think that's a very powerful precedent. The state has a tremendous influence through its convening power, bringing people together. That has been very important in a state like Arizona as well. And then a big question that's come up for some of us as we've studied this phenomenon. In workforce development, in most professions, the workforce development planning is based on known or anticipated demand for hiring in that profession. And in this case, with community health workers, because of the need for education of potential employers, the workforce development also includes the function of stimulating demand through employer education. Medicaid has an ambiguous role here. As I said Texas jumped into this a long time ago. 1999 was the original legislation. And it was explicitly driven by the desire of some legislators to have Medicaid pay for CHWs. But it is clear from experience that that did not happen automatically. And so the other big issue we've seen is that when folks are talking about CHWs, they're saying, well, where's Medicaid? Why isn't the state Medicaid office here? And the point is, it's not their job to define the scope of practice, let's say, for a profession. And so it's important they be involved, but they are uncomfortable with being part of that. Fee-for-service reimbursement, some people say that that's a dead-end street in terms of financing CHWs, but still a lot of services are still paid for that way. And so we do need to think about how that's going to work. Interesting, a lot of folks said after the Affordable Act had passed how important it was in terms of supporting CHWs. The only explicit support for CHWs was the authorization of a grant program that was never funded. So I do urge some caution in terms of putting our eggs in that basket. There are a number of things that are very helpful in the ACA, but it doesn't really create support for them, which leaves things in the hands of the states largely. A good example of that is this is an obscure section reference. This is the preventive services rule change in Medicaid, which came up in 2013, effective in 2014, saying that Medicaid could pay for preventive services that were recommended by clinical licensed clinicians. They don't have to be provided, meaning that non-licensed personnel can deliver certain of those services. And a lot of folks got very excited about that, but it has yet to be picked up 5 years later by any state. And so we need to recognize that the reality of that federal rule change did not fit very well with the reality in the states. On the next point, federally qualified health centers, in many states, there are federally qualified health centers doing great things with CHWs. Their financing is a little different compared to other providers. Many of them are still funded through a prospective payment system, and an encounter with a CHW only does not count as a billable visit. So some health centers have resorted to what they call flipping visits, which means that the patient has a contact with the CHW, and the CHW sets them up for a contact with a clinical provider in order to be able to help to cover the cost of the time that the CHW spends with that patient, because the clinical personnel can bill for that encounter. There are opportunities that some states have seen in district waivers in Medicaid and not others. That is a special kind of waiver, delivery system reform, incentive payments. And in the health homes that I mentioned earlier, some states have used these elements of federal policy as a way of advancing what they have been able to do. Some things that have tripped up this process. I just want to run through a few of them very quickly. It is very important that the practitioners, the members of the CHW profession in your state, are clear on and take ownership of the definition of a CHW. However, it is a very difficult thing, ethically and otherwise, to tell anyone they may not call themselves a CHW. That's one of the reasons why licensing is generally considered in this environment to be a bad idea, period. It is a sensitive topic. Let's just leave it at that. And that does create some challenges for policy development. In a related point, if you're going to be adopting at least a definition of community health worker in state policy, it is very difficult to assess shared life experience, or we commonly say being from the community or of the community. How do you assess that in an objective way as a qualification to become CHW. There are a lot of problems with that, and many of you, I'm sure, have grappled with that. And so it again should come back to the members of the profession to define that. A big issue that I've seen in looking at certification and the process that it's followed in multiple states, including states that have chosen not to pursue certification, is that stakeholders don't always disclose explicitly what they think certification means. It's complicated by the fact that in some states, the management of certification is under a body, in New York, it's State Department of Education, that licenses a lot of occupations, but they use the word certification even for those. And as I said a moment ago, licensing doesn't seem to be on the table for CHWs for multiple reasons. But there are people who hear the word certification, and for various reasons, they think licensing. And it, as we have seen where it's been implemented, it does not have to be that. And if the state is going to pursue certification, they need to do it in a way that is responsive to the distinct nature of this profession. They can't just do it a certain way because we certify other professions that way. That is not going to work. And so in a related point, of course, people may almost from a reflexive level either start from a position of support or opposition relative to certification. It's important to get them to articulate what are the beliefs about the consequences of certification, positive or negative, that underlie your support or opposition. Because again, those beliefs are not necessarily based in fact, and that what you do if you decide to implement certification in your state, what you do can be explicitly designed to respect those beliefs and avoid the negative consequences that can come from certification. We don't have time to talk about what those are at the moment. But and then the last one, again, just to echo Darrell's very crucial comments, that we have seen some states that have not followed good practice in terms of including CHW participation and leadership in policy development, and there are some negative consequences to that. So I will close with that, and after this session is over, if anyone wants to have a separate conversation with me, I will be glad to do that, but I'm looking forward to our discussion for the next 20 minutes or so. Thank you very much.
Great. Thank you all so much for these presentations. This was really informative, and we've received a number of questions. So I wanted to start with a question for Siobhan. You mentioned excluding patient navigators from your search and legal analysis when that term is used in connection with insurance reform. Could you explain the reasoning behind that?
Yes. So we started our community health worker policy surveillance back in 2011, I believe. And it was just as the ACA was essentially being rolled out. As we would find certain references to patient navigators in law, and I'm going to use Texas as an example, there may have also been community health workers addressed in the law too. And if we found references to patient navigators and we dig a little further, oftentimes they were related to either cancer control, and which actually ultimately ties to some federal grants, or the Affordable Care Act. And it's pretty clear as we read in the language around patient navigators related to health insurance that they weren't from the community. They didn't really fit with the definition of a community health worker along the lines of the American Public Health Association definition. They felt it really wasn't appropriate to include them in the analysis. So that is essentially the basic reason why we decided not to include that type of patient navigator.
Great, thank you so much. Okay, another question we received is how can we help ensure that CHW certification acts as a facilitator rather than an impediment to equitable involvement of CHWs in the health system? And I think this might have been what Carl was referencing earlier a bit and didn't have as much time to get into, but some concerns that this question raises are the cost of certification and any required training. So maybe we can start with Carl and then go around to anyone else that has something for that next one.
I'm sorry, I missed the last part of the question. I'm sorry.
This was about how can we ensure that CHW certification acts as a facilitator rather than an impediment to equitable involvement of CHWs in the health system. And the concerns raised were about the cost of certification and required training.
Sure. I'd say a couple of points about that real quick. That first of all, where it's been implemented, as I said, it's voluntary, and the employer is not obligated to hire a certified CHW. And indeed, if an employer finds a highly qualified CHW is connected to the community, has credibility in the community, and is committed to the community, they should be able to hire them even if they don't have a standard formalized training. Second, I would say that, yeah, the cost of training is a big issue, but I think that the good practice in this field indicates that it's better for the employer to hire the right person, meaning the right community background, the right shared lived experience with people in that position, and support them in getting any required training, so that the employer bears some responsibility for this. This is not unique, but it is somewhat unusual for the employer to pay for training post-hire. But that is, in many ways, better than requiring the person to pay for their own training and look for a job. It is definitely not. And I want to add to this, there was a question online about how to assure that this can be tied to Medicaid reimbursement without assuring that the CHWs are trained to deliver services. And I guess the point is that licensing generally means that it is illegal to do the work without being licensed. And that is not the case for CHWs. There are many ways of assuring that someone has qualifications, and I think setting basic skill requirements for people who are paid by Medicaid can be done through multiple mechanisms, but licensing probably should not be. If my fellow panelists want to add to that.
Yeah, I won't add to that piece unless someone else wants to, but just back to that original question, and I really see credentialing as a potential facilitator to better integration involvement in health systems and even social service systems that are basically designed in a way to support members of the workforce who have a foundation of training and or potentially a credential versus those who do not. I don't think that's the right system. It's the system that we have, and I've seen the work of CHWs involved, engaged in developing credentialing that isn't a barrier to the workforce to engage in the credentialing process. And sometimes you truly need members of the workforce to be in those decision-making roles to ensure that whatever the final regulations, whatever the cost per certificate, whatever the continual education requirements look like, having equitable engagement of the workforce in developing those, I think leads to that being a facilitator to involvement engagement in systems than being a barrier. And so, so that's my pitch to folks to get us at that table. Thank you.
Thank you. We've received a few questions about the distinction between licensure and certification, and so I just wanted to add some clarification on that point. From a legal perspective, both of these, both licensure and certification, can provide some protection to using a certain title, With regard to licensure, it provides an additional protection where it limits the practice of a particular profession to only those who are licensed in the state to perform those functions. So the scope of practice is it's a term that refers to functions that can be performed only by licensed individuals. And in contrast to that, for certification, if a certification statute defines the scope of practice, it's more so reflecting areas of competence, but is not limiting performance of those functions to individuals who are certified. And so the title protection that generally comes along with certification is something like only those who are certified may use the title certified CHW, but others may call themselves CHWs. They just can't reference themselves as certified or whatever that particular title is. Whereas for licensure, for example, a doctor of medicine, only a doctor who is licensed to practice medicine in that state can use that title and can perform those functions. So generally, certification is discussed in the context of CHWs because the purpose of licensure would be to prevent harm to the public associated with practice by unlicensed professionals. There's not that risk of harm associated with CHWs because they are generally not performing clinical functions and would only be performing clinical functions under the supervision of a licensed professional in most cases. So please add any additional questions if that was not clear, but I just wanted to address that distinction. In the context of CHWs, we're generally talking about certification because that's the most appropriate for the types of services that they're providing and does not exclude non-certified CHWs from performing those functions. Would anyone else on the panel like to add to that explanation? Okay.
I'll just add something quickly in practice. And so one of the first things we did, once again, a decade ago, in our first march towards looking at credentialing in Massachusetts was we had some experts from the Harrison Law Institute for Public Law come and talk with a couple of hundred CHWs in the state to truly define the terms, to talk about what it means when you say registry, when you say licensure, when you say certification, all of the things that fall under the credentialing umbrella. And so I would urge folks to ensure that those forums happen and that you have folks talk about those as you're thinking about what to do next in your state if you're looking at a credentialing of some sort. Thank you.
Great. So another question we have, what is the next step? I think for attendees, for advancing the community health worker through law and policy for all 50 states. And this question was, how can I help? So anyone have thoughts on the role of every variety of professions that may be attending today?
Yeah, I mean, it's been great. I mean, you've seen in the movement around the country, and I know Carl and others on this phone can probably contribute to this conversation, and that is that some of our key stakeholders, allies, and partners have been other professions, have been policymakers, have been administrators, and so I think my note about us all finding a role we can play, and that is that if you are getting notices about CHW policy meetings or conversations going on in your state, or even on the local level, because we haven't talked a lot about the local level, but there have been policies impacting CHWs, like say on city health departments, is to share that information with community health workers. And if CHWs are in your organization, ensuring that you find a way to assist them in getting engaged or involved in that. I think that goes with we all have a role to play if we are at the table helping to bring a CHW to that table, or let them even know the table is being set up. Thank you.
Great.
Anybody else?
Yeah, any other thoughts on that?
Yeah, this is Colleen Barbero. And one of the things we try to do at CDC is get out into the field as much as we can and engage with CHWs and go to meetings where they're speaking and learn about the different efforts going on in states. So I think just kind of being there to engage and hear about what's going on is really important. And that has helped us develop our perspective and really stay in touch with what's actually going on the ground and how the policies could potentially impact community health workers' everyday practice. So that's something we are trying to do as much as we can when there's an opportunity to hear from CHWs. We want to, we did have a forum at CDC where we invited CHWs to come speak to us about some of our program strategies, and there actually is a report on our website cited in our presentation slides that details the conversation at that meeting, but we will be continuing to try to participate as much as we can, and I think that's a good approach for other allies as well.
Great. Okay, I have another question from a community health worker. She says, it is difficult to be seen as a valuable part of patient care. How can we be seen as the imperative role we are? And perhaps in connection with communicating this role to policymakers as well.
This is Carl. Can I take a stab at that real quick?
Please do.
Okay. I think part of it, and others may have additional insight on it, but part of it has to do with the way healthcare is changing. The advent of medical homes and accountable care organizations, accountable communities for health, those structures require that healthcare organizations have certain capabilities they don't have now in the delivery of care. And those relate to things like relationship and trust and communication. They have to deliver, they have to do a better job on those kinds of things, especially with low-income populations. And their existing staffing doesn't really allow them to do that. The good news is that CHWs operate that way. This is how they produce results, is by entering into relationship, gaining the trust of individuals because of their peer relationships, their common life experience. And that extends especially to like hospitals who are the subject of historic mistrust in those communities. They have a tough time with mistrust out there. And the last part of this is that they're coming to recognize the impact of social determinants of health. And they are ill-equipped to address social determinants without somebody in the role like that of a community health worker. There are a lot of, I won't go into details about how CHWs affect determinants of health, but they are discovering that adds tremendous value. And I will summarize that by saying that the big trend, one of the big trends in healthcare, is shifting from a purely transactional approach to delivering services to more of a relationship-based approach to their patients. And that is where the strength of community health workers really adds tremendous value to what they need to be able to do.
And I echo Carl's words, particularly around the social determinants of health, because I've seen some states building in some indicators or benchmarks around social determinants of health and also around health equity, where CHWs can play and have been playing a critical and valuable role. But to the key point in the question, something that I kind of alluded to earlier, but that is what's the awareness? What are the materials? Are there fact sheets about CHWs? Years ago, the New England Regional Health Equity Council developed a 2-page fact sheet on CHW's role in health equity. We do health equity related things to in the community every day, but yet we don't use the language. And so we decided to try to shift and use some of that language, and so we develop materials with that. Some states have materials that just have basic information about community health workers. There are also community health workers who are doing grand round presentations, who are presenting posters at the conferences of other professions. And so I think we have to do outreach within our organizations and within systems, just like we do outreach in the community, in order to heighten awareness of our core roles, our skills, sharing things like the C3 report and other things that kind of give a snapshot on who CHWs are and what our everyday roles are in agencies and communities around the country. Thank you.
I'm just going to echo all the echoes. I also think that you can engage with hospitals as they develop their community health needs assessments and show them the evidence. There's a lot of evidence around the country that you can draw from, including at our CDC website. But if you can start the conversation with the hospitals through the Chinas, that would probably be a good start too.
Okay, I think we have time for one more question, and this one relates, I think, to being able to demonstrate the number of CHWs practicing or working in a particular area and tracking their work, documenting their work. There are two questions related to this. One asks, is there a widely accepted data platform that CHWs utilize to document and track their work that is most compatible with pulling impact reports to contribute towards policy development? And the other question is wondering how successful other states have been in quantifying the current supply of CHWs given the diversity of titles and the fact that many are not using the Department of Labor CHW job classification code. So I think we have very limited time for a response, but if anyone can offer some insight. Any thoughts on that one? That might be one to follow up offline if not, and we can see what we can find on those questions. Okay, I think we will wrap things up then with that. Thank you all so much for attending, and I want to thank again our excellent panelists today. I really appreciate everyone's participation and the very informative presentations. Back over to Charles.
Thanks, Colleen, and thank you all for your participation in today's webinar, and thank you again to our panelists for presenting today. I learned a lot, and I know our attendees did as well. So just a few final notes to all of our attendees. You will be receiving an email from the network with a video playback of this webinar, as well as a link to our really brief webinar survey. It takes just a minute to fill out, and it provides us with some great information and feedback, especially in regards to what topics you might be interested in for future webinars. You'll also be receiving an email from ASLME with information on how to apply for CLE credits for this webinar. And finally, be sure to check out next week's webinar, actually, ACA Under Threat, the potential impacts of repealing the Affordable Care Act on June 26th, and our upcoming Public Health Law Summit, focus on data sharing and community health this October. You can learn more about these events by visiting the events page on the network's website. That concludes today's event. Thank you all for attending, and have a great rest of your day.